Let's resume our session. We're a couple of minutes late. Our friend Bruno FALISSARD, who's a biostatistics professor and a psychiatrist, a member of the French Academy of Medicine. I got to know him when he talked about non-conventional treatments. There was a report of the INSERM, which is the public medical laboratory, and that's how I got to know him. Now I'm going to stand the floor to him. The subject of is destruction and reconstruction of evidence-based medicine. For a year now, we've been waiting to listen to him because we had to postpone last year's session to this year, as you know. I've got the impression I can speak without a mask. Yes, okay, fine. Yeah, it's better, because otherwise we won't be able to hear you well. I'm very happy to be able to make a conference in front of true people, physical people. It started yesterday. It's the kind of spring of conferences. I'm not an auriculotherapist. I'm not at all an auriculotherapy expert. So I may be saying things that you may deem silly or not relevant, and I may possibly vex you here. Anyway, there's a big issue today around what we call evidence-based medicine. So I suggest we talk about this subject, bearing in mind, at the origin, the intent was very positive here. It's something we can only praise. After the Second World War, and progressively, and then there was in 1990, we clearly reached the pinnacle. Colleagues in North America started saying, we are fed up of people saying that's how you're supposed to really treat people. We can't just have what they call themselves top experts saying that's how people need to be treated. So we need to be something a bit more scientific here in terms of our approach. So it's difficult to criticize, but it's always the same here. Behind the words, a lot of complicated things are hidden. For example, rational. What does rational mean? Well, in fact, not all philosophers agree on its definition. And the definition, which raises a certain consensus today, somebody is rational when they can implement what they need to do to be able to reach their objective. So, in fact, we're saying, before the word rational, who obeys or meets the rules of non-contradiction. Now, in the life of patients, it's complicated. Patients, by definition, aren't rational. Sometimes they say, I'm coming along, I'm afraid of being ill here, and I'm afraid of dying, and they're not willing to take their treatment, however. So that's not rational here. And us as healthcare professionals, we're not rational. Sometimes we're tired, or sometimes we say things that are non-therapeutic. And to be rational means it's to meet your objective, your end here, at the end. And proof or evidence. What's the definition of proof of evidence? Well, there are certain philosophers who say a proposal has been proven once it's recognized by a proven means, and it leads to a belief here. So you can clearly see, well, yes, okay, rationality, proof, evidence. It's complicated, let's face it. Now, in the field of medicine, it's even more complicated. But it's more complicated for historical reasons as well. Because de facto, in science, the doubt the doubt is the friend of a scientist to do an experiment, to find something. I need to doubt, I need to criticize it. My colleagues, my peers will doubt, will criticize. You have a review, you have a reading committee gets together, and it's anonymous here, and they shoot you down here, and they criticize you. And it's the scientific world is very tough from a critical point of view, and they permanently have you doubt. Now imagine you've got a physician who's doubting in front of you, a doctor who's doubting. It's not going to work. Healthcare healthcare physician, even though an MD, even though you've got a scientist in front of you here, if you're with him as a scientist, it's not going to work, is it? Because if you say, listen, you've got such a likelihood of having that, what does that mean? I mean, that's what's wrong with you. I'm not going to give you a drug, but you've got so much likelihood that it's going to work. That's the probability of working. That's the probability of not working. No, you can't say, I think that's the treatment, that's the diagnosis. I think that's what's wrong with you, and you need to take that because I think it's going to work. And you can see when you say it like that, well, the drug works better by definition. Everybody knows that. So the doubt is any doubt is an enemy to medicine. And that's the fact because patients are human beings and so are doctors. Doctors that are permanently in doubt, they can't sleep at night. So the problem is that if you've never got the slightest doubt, well, then you become a bad caregiver, a bad healthcare professional because you're not questioning your preconceived ideas. We've all got preconceived ideas. We all think we're good healthcare professionals because otherwise we wouldn't do our job. So I can see people, nodding or not nodding or saying yes or no. No, well, we consider that we're not that bad. Let's be honest. I mean, we don't think that bad of ourselves, do we? So, in fact, there's a kind of tension here between science and medicine. So that's life. Today, there's a permanent tilting point. One point, you either to the left or to the right here, or you drop on or what. Historically speaking, basically, before the 18th century here. I mean, since there was a pre-science with Wesel, but as of the end of the 18th century, with the century of Enlightenment, we have Claude Bernard and Pasteur in the 19th century. Enlightenment, the advance of knowledge, has to rely on rationality and science. So science totally took over medicine. And we can't say it's a bad thing because antibiotics were found and imagine medicine without antibiotics today. It would be worse than medicine without antiviral drugs. So there we go. A great success of science in medicine, Pasteur, Claude Bernard, those kind of people. So long live, hail vaccines here and antibiotics. And then in the 20th century, we're saying, yes, it's true, but it's more complicated than just that. In fact, science in medicine has many other hurdles, faces many hurdles, because a human being, by definition, is horribly complicated. So, in fact, we can't explain everything. There are certain doctors, MDs, after the Second World War, said that's a problem. How are we going to go about it? And they decided to use statistics, and they said, let's forget about classic science. No questions, you want that treatment? You ask in, does it work? Well, randomly, 100 patients in arm A, 100 patients in arm B. After 6 months, who's dead? If there's less dead with A, that means that A is good. So it really is a change of paradigm here. It's not at all the same way of thinking. And that led to treatment successes in cardiology, in oncology, in HIV. Without clinical trials, we wouldn't be where we are today. No. So great methodological success here. And then we move on to evidence-based medicine. The concept was created in 1986, and it was published afterwards. In the papers it was said, how should we build medicine? How should we build the medical practice with 3 circles? Number 1, the first circle was the data from clinical trials. You need to know, generally speaking, in what we call such a disease, such a condition, what works, and then what the patient wants. Well, the patient should be able to say, I don't want that treatment here because it has side effects, it has an impact on his sex life. Or then afterwards, it's a drug that another drug may not work quite as well, but it's up to the patient to decide. And then we had clinical expertise that came along. Because the people then, they say, well, That's the second circle. All these statistical results are for an average patient, a mean patient. But the patient you got in front of you isn't an average. He's always got specificities. It's up to the doctor, the MD, to can see, well, for that particular patient, well, normally we should be giving that particular drug. Well, I won't give that drug because I think it's going to be better for that particular patient. So we had the three circles here. So what happened afterwards? And I find that very good, by the way, here, evidence-based medicine. Well, why not? It's a pretty good idea, But then afterwards, there was a certain deviation that came from something that isn't mentioned enough. It came from the fact that since 1990, it's the admin people that have started managing hospitals. We got administrative people who are managing hospitals. And at the same time, we had the new public management. We have copied duplicated in the public sphere the management approach is from the private sector, reporting, whatever. So the admin people saw evidence-based medicine and said that's great. But there's one circle, which is the opinion of clinicians are not at all interested in that. You see that? Because if I allow clinicians to decide on treatment strategies which they consider are good, that doesn't suit me as an admin person here, as an administrative person. So the opinion of clinicians have disappeared. If you consider the French health authority in France, health authority, they say, well, if you disagree, you're allowed to prescribe something else. But that's not enough. And then it said, patients are allowed to choose, but we're always wary of patients, so we don't really talk to patients here. So there was a deviation of the evidence-based medicine. And we've only got statistical studies that are considered, which is a disaster here, because that's not how evidence-based medicine was set up initially. But that's life. And it went on and on. What has happened now? For the past 5, let's say 10 years, is beyond these issues, other issues have come along here. Now, before, and as you know, the drugs, you would get a label. When you had the label, they were reimbursed. Now, you may have a label, you may be authorized to market here, but some of them may not be reimbursed here by the National Health here, Social Security here. So there's a new paradigm, because these new drugs are so expensive, randomized trials aren't enough. You have to demonstrate that you are cost-effective here. That's a new thing. And then afterwards, the problem of implementation here. In fact, a drug, 20 milligrams of fluoxetine, be it in the USA or in France, give or take, it's the same. But we don't prescribe in the same way. We don't talk about it to patients in the way. Depending on how you talk about it with patients, fluoxetine doesn't have the same effect here. But let's say with an anti-cancer drug, there isn't too much of a placebo effect. But surgery, for example, such a procedure, surgical procedure, who's performing that procedure? We agree. Before getting spinal surgery, obviously you're going to find out a bit more about the surgeon here. Now, to actually say that care or that procedure is efficient without considering who's going to perform the procedure, how the person was trained, how long is he going to spend with you during the consultation, obviously the outcome won't be the same here. So there's a problem in terms of the sheer implementation. Other people have said there's a problem from a scientific point of view. In evidence-based medicine, there's no fundamental science here. The mechanism of action of a given drug is not involved in the decision from an efficacy point of view, which is strange, really. A good mechanism of action, in fact, we can care less, except in certain surgical procedures. A beautiful surgical procedure, even without clinical trials, surgeons will go for it because we've got pathophysiology that's involved here. Reaching a stage where evidence-based medicine is starting to crack here. It's been attacked and criticized because from a clinical point of view, it's a problem for the payers. There's a pragmatic point of view from an implementation point of view. And our patient groups that are saying in oncology, you're saying that chemotherapy is efficient, but we're vomiting, and you should ask us for our opinion before giving those drugs to us. So now, that's the situation today. And it's the time to rebuild and to come up with a new or another evidence-based medicine. Now, there are things that are easy and straightforward and others that are difficult. What's easy is to talk about implementation. We're offering a new approach here. There are questions which we need to consider now, which we didn't consider. What's the content of the care? Because in a given pill, a tablet, it's stated. But we saw this, by the way, for Levothyrox and all that. And for the thyroid, it isn't as straightforward as we may think. It isn't that straightforward. Remember that particular case. Now, for drugs, we're talking about biochemistry, chemistry. You can dose it, there are instruments to dose, so it's relatively easy. When you're talking about surgery, it's a bit more complicated. When you're talking about psychotherapy, it's even more complicated. And in fact, even though we're going to do TCCs here, you perform TCCs. How were the people? So that's behavioral treatment here. How many sessions? One a week? Is it the same? One session a week for 6 months? Is it the same as, I don't know, 3 sessions a week over 2 months? You have to define the content of the care that's going to be provided here, the duration of the consultation, and even the price of a given consultation here should even be considered. Behavioral treatments here. Now, that isn't expensive, but it should be done so here. Then afterwards, the question of cost effectiveness here. We know random trials aren't great if you talk about cost effectiveness. The Anglo-Americans are pretty good. I mean, it's the cost effectiveness that leads to the reimbursements. In the UK, they reimburse based on the cost for an additional year of life gained. So the human, basically the price is 3 million euros a year, or in France it's the same. It may shock you, but it's the same in France, but we don't say it here. I'm exaggerating. In medicine, you got that. You've got the what we call the high French health authority here, but it's not there isn't a cut-off point like in the UK. There isn't a true cut-off in palliative care and oncology. It's not the same, but you may wonder why. But anyway, but in fact, now randomized trials are interesting, but it's more to consider cohort epidemiological studies, which we see more and more. Now, the point of view of the patients, you got measurements in terms of quality of life, interesting, but we can do better. We can have qualitative studies, open interviews. We ask 20 women who are on chemotherapy for breast cancer. What's the impact on their quality of life, their sex life, the impact on their hair, the fact that you may feel better, or you feel better, or you don't feel better. So we need to perform qualitative studies to see how people live here. These treatments can be very tough and are chronic here and has a huge impact on quality of life. Now that's easy, but afterwards, how are we going to introduce scientific knowledge, which is fundamental scientific knowledge in terms of the assessment of treatments? There's a definite challenge there. Beyond evidence-based medicine, we've got science-based medicine that exists here. And in fact, they're even tougher than evidence-based medicine. They criticize evidence-based medicine because evidence-based medicine doesn't focus on fundamental biology. So for a treatment to be effective, on top of that, you need to find a clear mechanism of action that's explained by science, which means by biology. So there's a question there. The issue there. Is this a medicine based on science, or is it based on scientism here? Why? Because in fact, why does it work if it would work if science could explain everything that's going on in a patient? That would be great, but it's not true. If you take a torsal, if you got backache, lower backache, here you can find out if it's a nerve or is it a muscle. But there are a lot of different nerves and muscles here. Usually it's a bundle, usually sat down. No mammal spends 8 hours a day sitting here. I mean, we're not made for that as human beings. Things take place. There's a torsion. Physiotherapists, osteopaths, orthopedics, they know. Because I may because I don't know, I got a sore foot, I may end up with a hip arthrosis here. All that's complicated. Why have you got backache? Because you sat in front of your computer, because your boss is telling you off here, so you're stressed out, so your back muscles are tense here, or you're too fat. Why are you fat? Because you're not moving enough. Why? Because that's our society today. You see how complicated it is. There isn't one single science that enables to explain everything here. So, in fact, thus, how? I mean, we can see on the other side that care with a strong scientific base isn't interesting. So today there wasn't a single month that goes by when a new anti-cancer drug isn't approved without randomized trial data. It's just a cohort of patients, and we just have a look of, I don't know, the growth, that particular growth actually disappearing in the spine here. Why? Because we've appreciated the mechanism of action. So logically it's supposed to work. We consider the mechanism of action. It's incredible here. You can see that there's a disruption from an epistemological point of view in terms of drug development, that particular authorization, but the paying people who are paying for it, the authorities, we're not paying for a mechanism of action. It's the good we're doing for the citizens here. Now, time's flying. I'm reaching my conclusion here. Now, in fact, there's a tension around science here, and I really think a lot of care cannot clearly define a mechanism of action, but there's a lot of care provided, in particular non-conventional caregiving, that talks about semi-mechanisms of action here. Now, I'm not going to talk about Auriculotherapy because it's not a subject I know, but acupuncture. You know acupuncture, don't you? Well, acupuncture, there's a theory, there are mechanisms of action here, or suggested at least. But as you know, you got experiences, there's been randomized trials to talk about the meridians here, and those trials haven't worked that well, really. Don't want to raise a discussion. It's like in the 19th century, in fact, here, with the theory of miasma. I don't know if you're aware of that. In the 19th centuries here, when there was an epidemic, we thought it was the bad smell that would actually transmit the epidemic here. Now, you would have used certain plants to get rid of a lot of bad smell, miasma here. It would be transported in air and it would transmit the disease here. And that question, we had it in the case of cholera here. People say, no, it's not due to the air, it's contact, it's water, but yes or no or whatever. Obviously, you all know miasma, it's not really that, it's microbes we're talking about, it's germs we're talking about here. But for cholera, they got angry here, and we were able to demonstrate statistically that it wasn't via air, it was via water. It was John Snow in London who demonstrated that. But in fact, now we know today that if we air the rooms, it's better for epidemics, to fight against epidemics here. So the theory of miasma, in a brutal way, is kind of wrong, but it isn't as wrong as we thought it was. If we just consider things from a pragmatic point of view, it's a kind of semi-truth, or it's half false here, because it's partly true. It's true there may be a contagion through air here. It's not because of the smell here, even though, you know, there are a lot of bacterial infections that have a pungent smell here. There are people who had a certain intuition and they came up with theories which we could call neo-Hippocratical theories here. And if you consider Auguste Comte, it's a pragmatic metaphysicism. It's not purely scientific, it's an intellectual construction that explains the world here, based on observation of everyday life. And I think in acupuncture, we're at the same stage here. It's kind of half true what the acupuncturists are telling us here, and I would differentiate what they're saying compared to what they're doing here. And this is one of my colleagues who's an osteopath who's amazing, who told me that, he said, their words are wrong, but their hands are true. A lot of the discourse of osteopaths is wrong. They're talking about miasma. But in fact, the gestures are correct, like opening windows is a good idea. Now, I think There's a whole field of medicine that's in a similar situation. Now I'm reaching my conclusion here. What should we actually do? Well, number one, evidence-based medicine is being challenged, and that's a good thing. And then afterwards, there are solutions, easy things, like I said. We need to define who are the caregivers, the healthcare professionals, how are they trained, for how long are we going to take? Because I don't know, if you spend 10 minutes per patient, only by prescribing a pill or a tablet won't have the same efficiency as if you spend a half an hour with the patient. So time is important. So how do you provide care? Then you need to question the patient's qualitative study and be humble. We need to be humble because the stories we hear about how care works, to be honest, we don't really know much at all. Now, you've got biology, and we need to recognize that biology has enabled to discover vaccines, antibiotics, anti-cancer, biotherapies, not bad at all. So medicine has greatly changed since the great arrival of biology, and that needs to be clearly stated as well. But biology can't enable to do everything. Doesn't enable us to do everything. We need to move forward in terms of fundamental science to come up with sciences, not just a single science, but multiple sciences, will enable us to explain how caregiving is provided, and considering the non-rationality of patients, because that's life. That's the only way we can move forward, by offering the care our citizens are expecting. Thank you for your time. Obviously, let's thank our friend who has stated things which we have all thought for many years now. Unfortunately, when we see medicine today, there's a certain technocratic, bureaucratic approach which is a total nightmare. And personally, I'm in the private sector, so I don't face it. I've got a daughter who's a psychiatrist in a hospital setting. It's a fantastic job, but it's a total nightmare because we can see an administrative evolution, and all my daughter wants to do is to care for her patients, and above that, the bureaucracy is doing crazy things, and we've got the impression that we can't do anything for our patients. I mean, all you're doing is being on the computer and just ticking the right boxes here. So we agree with what you say here. Now, us in Auriculotherapy, we are trying to move forward on both aspects here. We want to move forward on the clinical aspect because our results are absolutely amazing here. If you're not really trying to be rational, it's kind of amazing. Somebody comes along, can't walk, and we're doing something for them, and they can walk now. And in fact, no, there's a bit of neurology here, pressing on points, which stimulating certain areas here. So we are clinicians, but at the same time, we've got this medical background and education. We want to understand. We're trying to find systems in terms of research and R&D. It's a shame you weren't here when Michel Marignan was speaking, who's a scientist, and he's trying to find ways in the field of neurology to understand what we're doing. So, in everything you're saying, we can recognize ourselves. Are there any questions? Because I'm just talking here, but I've got my mic here. Any questions? Now, our friend Julien, who's kind of hidden in the back of the room, as usual. Now, you're one of the bosses here, one of the professors here, because you belong to the Academy of Medicine. But at the same time, you're a GP. So, and on top of that, you are a countryside-based GP here. What do you think about the double blind treatment when in cancer patients, and we give a chance of people to be able to be treated and others who haven't got the slightest chance to be treated? When you talk about double-blind approaches, we're talking about oncology here. Now, I'm going to hand the mic to Bruno FALISSARD, and I think his answer is going to be very interesting. Well, in principle, in a randomized trial, We need to unequally rate it. There should be a lack of chance depending on the group you belong to. Now, in practice, let's be honest, it's not always true. I would say there are two things here. From a principle point of view, we consider if there's not less of a chance of something happening if you weren't included in the trial, then it's not shocking from an ethical point of view. So, for example, if it's an anti-cancer drug and it's third line, you're metastatic and there aren't any other available treatments, well then we can give you a placebo. Especially, generally speaking, patients who are included in these trials tend to be better cared for because there's more imaging, they're seen more often by healthcare professionals, so it's acceptable from an ethical point of view. But then afterwards, it's not always the case, unfortunately. There are certain cases where it's true what you said. Within the trial, if you're in the control arm, you are possibly got less of a chance than the other patients in the other arm. And let's be honest, there, it's not necessarily nice, but it's the reality. There are in certain countries, if you don't belong to the trial and you're dead, well, you won't be cared for anyway. Well, then the trial becomes the truth. Which is why we have a lot less trials than in Eastern Europe and South America and even in the United States. In the United States, if you haven't got any money, it's difficult to get cared for. So those ethical issues are hugely complicated, and even more so in our country, in France, because we're fortunate enough to have a healthcare system which is quite fair and quite generous, despite what everybody says. Because if you go elsewhere, believe me, you're surprised. Well, thank you very much.